I want to say in big, bold letters, this lady discovered the gene for pancreatic cancer. That's a super big deal. A super big deal. Okay. So it's really my privilege to introduce you tonight. She's the Walters Endowed Chair Professor of Medicine in GI and Adjunct Professor in Path, and founder and director of Pancreatic Cancer Surveillance Program at UW Medical Center. She sees a lot of patients and deals with diseases in the GI tract. And again, she's the lead, she leads a team in the discovery of a specific gene, pallidin, for a certain type of familial pancreatic cancer. And here she is with her mom. And here she's vacationing in Italy. But she leads the pancreatic surveillance program at the University of Washington. She, as you know, earned her medical degree at University of Washington, the third row back from our lecture hall, and did her residency at UCLA.
So our topic today is predicting and preventing disease, early diagnostics for all. That's what we're going to talk about. And we're going to keep you on your toes because making the right diagnosis at the right time is just such a great thing. The other name of the talk today is Madness and Mayhem of Molecular Medicine. So we're not just going to talk about diagnosis because that was the other 9 years of mini medical school. Okay, so now we're moving on. So we're going to talk about molecular medicine. I know those are a scary phrase there. You're like, molecular, I don't know, I don't think I can do that. But you can. By the end of the evening, you can. All right, so on we go. So I'm going to talk initially where the world in which I live, which is the world of let's make a diagnosis of cancer very early while it's still curable. But the things I'm going to talk about tonight could be apropos of any disease. We always want to make a diagnosis of a disease early. So you know from previous mini medical schools that there's always the physical exam where you have to touch the patient. And there's blood tests. We always like to get a lot of those. And you can also test bodily fluids other than blood. And then there's imaging tests. And since we have some radiologists with us tonight, I thought we could embark on that a little bit. So in the case in point here, I'm going to talk about pancreatic cancer because that's my little area of expertise. And pancreatic cancer is a very deadly cancer. It's the fourth most common cause of cancer death in the United States. And as of next year, it'll be number three cause of cancer death. So it's a bad player, and it's very hard to detect it when it's early and curable. Very, very hard, which is why it's a common cause of cancer death. And the reason for that is most patients have no symptoms. So they're just walking around, they think life is good, and then one day, the day they get their symptoms, we make a diagnosis eventually, and usually the tumor is really big. So if you wanted to go into early detection of pancreatic cancer, we could go over the things we just talked about. Physical exam. Can you feel the pancreas on the physical exam? Come on, guys. You've been here 10 years. What's the answer? No. The answer is no. Okay. Is there a blood test for pancreatic cancer? No. Is there any bodily fluid that you could send off to somebody in the Mayo Clinic to test for pancreatic cancer? No. Okay, good, excellent. So what does that leave us with? That leaves us with some imaging tests. Now these imaging tests, although I am a big proponent of getting x-rays and x-ray-like items like a CT scan, they're good for some things, but in pancreatic cancer they're particularly difficult. And let's talk about a little bit about that. So the optimal imaging of pancreatic cancer, if we were going to do it, you could pick any imaging test for pancreatic cancer. The ideal would be it'd be super inexpensive. Look, right up front, inexpensive. It'd be readily available, so you don't just have to go to one little center in the middle of the North Pole to get it. You could get it at any center. Highly accurate. They say you have cancer, you have cancer. Not one of those, gosh, it could be cancer, but maybe it's not, and why don't you come back in 6 months and we'll take another peek. That one is, oh, God, you're waiting by the calendar. All right, so let's talk about accuracy in imaging. It's good for a CT scan can catch things that are this big. This is a walnut. And they can catch things that are this size pretty easily. But the truth of the matter is, if your pancreatic cancer is this size, it's usually not curable. Catch it between a dime and a pea, more toward the pea size. Now you're getting into the pretty curable zone. But if you could really get it over here in the rice size to pea size, now you're very curable. But it's really hard to find things that are rice size. Now I want you to know, if you look at these pictures, it's rice to pea, pea to dime, and so this should be dime to walnut, right? Wouldn't that what you would think? But when I went to Google to get a picture of a dime and a walnut, this is what I got. Can you believe that? Now, I challenge you. You go out there and Google that, and that is what you're going to get. All right? Giuliani with a chicken on his head. I don't know. So I just thought I'd share that with you because it fascinates me. All right. But now, back to our talk. So, out of all the imaging tests, let's go back. Well, we got to find something the size of a piece of rice, okay? So, and by the way, it has to be inexpensive, and it has to be accurate, and it has to be available at various medical centers. So I chose ultrasound. So ultrasound is one of the most common diagnostic imaging methods. Everybody's got an ultrasound. They're at all the clinics. Everybody has it. It's great. Okay. We also like it because there's no radiation exposure. Like on a CAT scan or your basic chest x-ray, you get some radiation. We're against radiation, just on principle. So any test that we can do where you don't get radiation is always nice. All right, you can repeat it frequently, no problem there, especially if it's inexpensive. And it costs cents on the dollar. So where you might spend thousands of dollars for a CT scan, ultrasound might be a couple $100. Now, I'm going to bring up this molecular medicine idea here because right now, a standard ultrasound would have trouble finding pancreatic cancer, even the size of a walnut, but if you wanted to get down to the size of a piece of rice, it's not going to happen. Just not going to happen. So let's make it happen. Let's figure out how to make it happen. So this newer method of ultrasound can enhance the cancer image by lighting up the blood vessels in the cancer. It brightens up the blood vessels in a cancer. Now, how do we do that? By making them red and making them look larger. So I'm going to talk to you about a concept here. This is going to be your big medical school concept today. We're going to talk about this term neoangiogenesis. So angiogenesis means the growth of a blood vessel, and neo means new, and it pertains to cancer. So this is the growth of new blood vessels in a cancer. So the term we use for that, new blood vessels growing in a cancer, is neoangiogenesis, okay? And the thing that is nice about this is the new blood vessels that a cancer makes is different than the usual blood vessels in the rest of your body. So what happens is, here's your little tumor up here. Those are your little tumor cells there. And when they get big enough, they're like, where's the food? Where's the blood supply? Where's the oxygen? And there is no oxygen or blood supply. Once it gets really big, it needs to have some blood vessels get in there to supply the food and the oxygen and the blood supply. So the tumor sends out little signals, that's those little dots there, and says, could somebody send up some blood, make some blood vessels our way? So these little blood vessels break out of a normal blood vessel and they head up to the tumor and they supply the tumor with the blood vessels. Okay, so that's how the tumor gets the blood supply. It sends out for blood, sends out for blood vessels, and in they come. They just grow right in there. Now, those blood vessels are not normal. They're abnormal. And that's what I tell my children. You're not normal. You're abnormal. The thing about these blood vessels is they're leaky, and they're a little bit made out of weird things. So we're going to talk about that too. So what we do with this ultrasound is the idea would be, see if we can target these blood vessels with what we call little micro bubbles. So I'm going to make little bubbles full of gas, tiny little bubbles, just like in champagne. And I'll inject them into the bloodstream, and they'll have little binding agents on them, and they'll float around in the bloodstream, and when they get to the abnormal blood vessels, they'll bind to it. And those little champagne bubbles are really easy to see with an ultrasound. So that is pretty cool. And then, after a couple hours, the little champagne bubbles, just like a glass of champagne where it would go flat over time, those little bubbles dissipate and they disappear and it's all gone. So it doesn't cause any side effects. We like that. So the key to this is making micro bubbles that can bind on to these abnormal blood vessels that are in the cancer. So I'm going to show you an example. I couldn't get the video to work, so I'm just going to show you. This is a tumor right here. This dark area here is a tumor, and it's sitting under a piece of skin. And what happens is, right now, if you had to find that just using ultrasound, well, I've blown this up so it's gigantic. I mean, you might be able to see it, but you'd be like, oh, you know, it's dark, but is that really a tumor? But then, if you put the microbubbles in, you can see them light up and bounce around, and it makes it really easy to target. All right. Using this technique, we can find a cancer that is the size of a piece of rice. We can do that right now. So right now what we're doing is we're going to try and get the FDA to agree that microbubbles are okay for use in humans, because right now we can only use it in mice. So the mice have early detection for pancreatic cancer, but the humans do not. All right, now, to get back to molecular medicine, how did we get here? How do we get here? Well, before the rice, we were talking about the microbubbles, and before the microbubbles, we were talking about the tumor. Before the tumor, we talked about Rudy Giuliani and his chicken, and before that, we talked about the tumor and neoangiogenesis. And that leads us to here. Here we are in the abnormal blood vessel, and we want these microbubbles to bind on here. And so how are we going to make that happen? We have to determine what these little proteins are on the inside of these abnormal blood vessels. We have to figure out what those proteins are. So how do you discover a neoangiogenesis protein? And I know you guys came in today thinking that exact question. You were like, God, I hope they talk about this tonight, because that is bugging me. All right, so how does the scientist find any cancer marker? How do we do any of it? I know you think it's magic. And I tell my children that it's magic, but it's not magic. It sort of relies on you understanding how your various body parts, including cancer, are built. So what are we made out of? When I touch you, what am I really touching? Okay, so we're going to talk about that. So to do this, we have to go back to basics. Now, I'm not going to quiz you on this. I just want you to just stay awake for the next couple slides. Bear with me. All right. So we are all, you know, made out of DNA. That is the stuff of life. Everybody's heard that, the stuff of life, DNA. That is the genetic code. Now, in every cell, we have all the DNA we need to make our body parts, all of our body parts. It's a huge amount of DNA. But we don't really, if I was just going to make a few proteins or I wanted to make an ear or a hand, I don't need the whole long, thing of DNA. I just need the part that pertains to making a hand, for example, or a protein, a blood vessel. I just want the part for the blood vessel, please. I don't want to have the whole thing, just the part for the blood vessel. So if you just need part of it, the way to get just that one little part is called transcription. So it's like you have a book of DNA, and if you just want the part for the blood vessel, that's called transcription. And what that makes is RNA. So that's an intermediate little gizmo. We'll call it a gizmo, little stuff of life. Now, because this is written in genetic code, nobody can understand it. So we have to have it translated. And it gets translated into a language that the body understands where you make proteins. And when I touch you, you are made out of proteins. And those proteins are there because you start out with the DNA, which turns into RNA, which eventually turns into protein, okay? And so people talk about DNA and they talk about RNA, but at the end of the day, when I touch you, you're made out of proteins. Now, when we talk about systematic discovery of specific things, like I want to find out what's inside those abnormal blood vessels, when we talk about systematic discovery of specific things, if we talk about systematic discovery of DNA, all the DNA in a cancer, that's called genomics, okay? And so you're going to hear the word genomics because people are talking about it now. They're talking about it for healthcare. We want to know the genomics of your particular cancer. Now, if we talk about systematic discovery of the RNA, that's called transcriptomics. And when we talk about systematic discovery of all the proteins in something, like all the proteins in this blood vessel, that's called proteomics. And that's what I do. I do proteomics. All right, so to discover the key proteins in these blood vessels, we used what we call proteomic analysis. And that is what allows us to image the blood vessels, the ones that are in normal tissue, and we can compare those blood vessels to the blood vessels in cancer. And that proteomic analysis can tell me the difference between the cancer proteins and the normal proteins, okay? So for example, right here, this is a blood vessel inside a pancreatic cancer, and you can't see it very well. But when we did our proteomic discovery, I was able to find all the proteins that are inside this abnormal cancer blood vessel, and then we were able to look for them. And once we discovered what they were, we could build a stain around them. And now I've stained for this protein, and you can see the black staining around the blood vessel makes it really stand out. And I've stained the protein that we ended up using in those microbubbles we made. So I just took that protein and I hooked it onto a microbubble, and now when it gets inside the bad blood vessel, it hooks on there. Very simple. Now you can use these omic principles in medicine. So you could use it to make a blood test. I want to see what the bad proteins are that are shed by a cancer into your bloodstream. So I could use it that way. So you could look at proteins in the blood from normal patients, and you could compare it to proteins in the blood from cancer patients. You could also do it and say, well, what are the proteins that cause a disease? Because if I can understand that, I can build a drug that will fix those proteins that are broken. So you would compare normal tissue to diseased tissue, in this case, cancer tissue. So molecular medicine is really coming of age. It's really like a big hot thing in the National Institute of Health and among scientists right now, and certainly in the world of cancer. So there's been a development of diagnostic tests built around this molecular medicine. Better imaging has been ongoing because of this molecular medicine. And identification of abnormalities and disease for new drug development is going on because of these new developments in molecular medicine. Moreover, this is the big hot thing now. It's called personalized medicine. So what would happen is if you have some tumor that is difficult to treat, we could take your tumor off and do that systematic investigation of your tumor and see what's in it. We could see what proteins were in it or what genes are damaged in it. And then I can say, you're better off with this chemotherapy regimen because we looked at the profile of your tumor and your tumor shows me that it has these bad damaged proteins in them, and we're going to target those. And so that is just coming online now. There are just now having matching drugs for given targets that are broken in a tumor. All right, so before I close, I want to give you another example of how we might use this. So in pancreatic cancer, a lot of people die within a year or two of their disease, but occasionally, very occasionally, you might meet somebody who got out like 5 or 10 years. And I'm all about, how did you do that? And you know, some people are like, well, they didn't really have pancreatic cancer. But we go back, we look at their tumor. Yes, they did have pancreatic cancer. So this little conundrum like buzzed around in my head for a long time. I was like, what is it about someone who, both of them have pancreatic cancer, but this one gets to live 10 years, and that one dies within 1 year? And so we did a study just this year to compare the tissue, the cancer, between long-term survivors of pancreatic cancer, people who had their disease 10 years or more, and short-term survivors, people who died of their disease within 1 year. And we did, now you know about proteomics, we studied the proteins, a systematic study of the proteins comparing the tissues between these two groups of people. And we discovered there's 27 proteins. That's what's the difference between you live in 10 years and you live in 1 year, 27 proteins. Like, my God, that's not very many. And so we prioritized those proteins, and 9 of these proteins that we prioritized are very low in the long-term survivors. They don't have very much of these proteins, and 4 of them are very high. They have a lot of that protein. And one of those proteins we entitled gilpin, and it turns out its levels are very low in long-term survivors. They don't have a lot of gilpin. So I'm going to show you, this is a pancreatic cancer of a short-term survivor here on the left, and this brown staining is all staining for gilpin, and they have loads of it. And this is a pancreatic cancer of somebody who lived 10 years, and they have none of it. And it's amazing. I can just look at their tumor block and tell who's going to be in trouble and who's not in trouble. Now, that's really helpful because it helps me plan in terms of, you know, we got to be fast in managing the short-term survivor. We don't have a lot of time to change out chemotherapy regimens, and we need to get moving here. Also, it tells me if we can get rid of this protein, maybe we do this person a favor. So maybe we should be developing some kind of medication to get rid of this protein. So we got together with our friends at Johns Hopkins and we studied, each one of these dots represents a person. And we said, how much of this protein is there staining on the short-term survivors? And practically all of them have a lot of staining. But if you look over here, most of the long-term survivors have little to no staining. And so when you do, if you looked at, this is what we call a survival curve, and every time you take a step down, it means somebody died. So if you look at people that are gilpin negative, only 2 people took a step down, and the rest of them are all still alive. But if you look here, all of the people that were gilpin positive ended up dying within 5 years. So what does gilpin do? Well, it turns out that it plays a role in immunology, and then there are medicines that probably could be used to treat this. And by knowing that this protein might be upregulated in some people, that they have it in their tumor, it might help me think, okay, this might be a person that we should target with a personalized medicine. We need to use a gilpin, antagonist, a gilpin fighter for that person. And that also helps us understand a little bit about pancreatic cancer, because when I find out, oh, this this protein has something to do with immunology, it makes me think, I wonder if the immune system is really behaving in pancreatic cancer. You know, maybe it's not behaving. So it helps me go to the mechanism of what's going on under disease. So just in review tonight, I wanted to go over with you some molecular medicine. And I just wanted to note that when we want to apply our molecular medicine, we talked about neoangiogenesis proteins. Those are the proteins in the new cancer blood vessels. They can be exploited to help you find cancer when it's very small. Molecular ultrasound, a very inexpensive test, can find cancer that's the size of a piece of rice. How much do you think those microbubbles cost? Anybody?
$50 a piece.
25. Okay. 25 for a little vial of them, not per bubble. All right. We've been able to identify proteins in long-term survivors, and it may help us predict how well they're going to do with certain chemotherapy and help us think about what we should target for their treatment. What else have we learned tonight through this talk that I've just given? Well, we talked about how does DNA turn into a protein, so we reviewed that. We talked about the systematic study of DNA, RNA, and protein is genomics, transcriptomics, and proteomics. We talked about how molecular medicine is moving to the forefront now. People are really starting to think about how can I tailor your therapy to your disease? And it's not going to just play a role in cancer, it's probably going to play a role in other diseases as well. And my belief is that the greatest benefit that this is going to have is in improving our methods of early diagnosis of diseases. So we've learned about neoangiogenesis. We've learned that neoangiogenesis proteins help identify cancer. Molecular ultrasound can find cancer the size of a piece of rice. We learned that that's what an ultrasound looks like. And that's what little frog, Kermit the Frog ultrasound bubbles look like. All right, thank you very much.